Kill the engine there. Jay, welcome to virtual Las Vegas.
Thank you. Hi, Matt. Nice to see you.
You know, we're here alongside virtual AAO, and you're in America, but your experience is particularly interesting to us back in Asia, where we're actually here in Vietnam set up, because you have worked on a study, a consensus study about DME for Asia Pacific. Can you tell us a little more about that?
Yeah, this is one of the studies which I worked when I was in India, and we decided that we will try to establish the DME guidelines. As you understand, diabetes is very, very prevalent in India, but not only prevalent, but it is increasing across the world. But one of the challenges which we faced in real life in India was that we really had to struggle hard between the treatment options, the cost associated. Not many patients have insurance. And there were many guidelines for many countries, but we learned that there is nothing specific for Asia Pacific region. So we decided to establish the consensus guideline and brought in many specialists, expert and experienced people from different countries and brought in their experience, and we established the consensus guidelines.
So Jay, you mentioned that the consensus guidelines for DME are established in the US and in Europe, but not in Asia Pacific. Why has that been?
Maybe just that people thought about that before, and we were lacking somewhere in newer treatment options, which eventually became very common and available to us. And I think this was the right time to bring in the consensus guidelines.
You know, that's really interesting. So Jay, everybody wants to know, what are these guidelines saying?
So let me give you a brief history about how did we go about this. So we picked up retina experts in various countries in the Asia Pacific region. We established almost 47 questions for them, and these questions were pretty much about practice pattern and how do they manage their DME patients. And the most important thing which I find is unique for this particular paper or for this particular consensus guidelines is that we actually brought in some very important part of the treatment plan, which is the cost and the compliance issues while managing these patients. And we also emphasized on the complications associated while you're treating these patients, such as increase in intraocular pressure, cataract, and we could bring up the consensus even to manage these complications. So just to brief you up about the treatment guidelines is that we established the target response for these DME patients. Then we divided the treatment response in terms of adequate response, inadequate response, and non-response. Just to summarize how this response was established was that if you are able to achieve 6.6 or the central macular thickness that is less than 300 on OCT, this is our target response. And then we came up with the management of various complications such as cataract formation. How do you manage cataract if the patient already has cataract when you start treating these patients? How do you manage increase in intraocular pressure? And very beautifully, we have come up with the approach to this increase in intraocular pressure while managing these patients. And along with that, we came up with how do you actually evaluate the OCT in these patients if you have certain epiretinal membrane, and if you see any chronic edema, how do you manage these patients during the course?
Jay, I'm sure everybody wants to know as well, what treatments are recommended in the guidelines?
See, what we did was we understand that whenever we see a new patient with diabetic macular edema, we want to start with anti-VEGF injections, which is one of the most common and approved therapy for diabetic macular edema. But I think one of the biggest achievement we have from this guideline is that when do you actually switch to intravitreal steroid? Because intravitreal steroid is also one of the most effective way of treating the diabetic macular edema. So just to brief you up about the history is that many of the physicians, especially the Western world, believes in switching these patients after 6 intravitreal anti-VEGF therapy to steroids. But with my experience and many of us in Asia Pacific region, because I did do an APVRS survey when I was in India in 2016, 2017, I think, where we learned that many of the retina specialists in Asia Pacific region would like to switch their patients after 2 to 3 injections of anti-VEGF therapy. Because we realized that we really cannot give 6-7 injections, then we decide to switch, but rather we would like to switch earlier. And this is something which we learn even from this consensus guidelines, and we recommend that we should be switching the patients to intravitreal steroid treatment after 3 injections of anti-VEGF. And we nicely brought out the inadequate response guidelines, that when do you actually decide to switch the patients to steroids. One very important thing which we really lined up really well was when do you actually treat your patients with your primary dexamethasone implant. I know that we would like to recommend primary treatment as anti-VEGF for diabetic macular edema. However, there are certain situations where you would like to offer intravitreal steroid or dexamethasone implant as the first line treatment, such as when you have patients who are at high risk of cardiovascular disease, cerebrovascular stroke. When you see your patient for the first time, but by looking at this, you know that this is a persistent DME, though the patient was never treated. Patient with pseudophakia, you can easily offer them as intravitreal dexamethasone implant. And these are few of the things where we would like to offer a dexamethasone implant as their first choice.
So Jay, just to recap, basically, you're saying that intravitreal steroids could be used as a first-line treatment. In addition to that, you could, follow up an anti-VEGF injection after a number of rounds with an intravitreal steroid as well successfully.
Yeah, and very important thing which I would like to add is that you should be considering switching to intravitreal steroids maybe after 3 anti-VEGF injections. You don't have to continue for longer, and we would like to switch them much earlier. 3 is the number, yes.
Magic number 3. Okay, I got it. All right, Jay. Well, it's been real. I appreciate you joining us in virtual Las Vegas, and we'll see you next time at our Pie and Cake Talks.
Thank you so much. Enjoy.
All right.
All right, it was fun. It's impressive that how you come up with these ideas, honestly.
Hey, thanks, Jay. Well, I didn't have much room to ride there. There was like a brick wall right over here, so.
I was worried that you'll bump into the wall.
Well, hey, I really appreciate it. Really good hanging out. We can do interviews anytime and talk about all kinds of things, so.
Yeah, absolutely. We'll be happy to work with you, definitely, anytime.